Good afternoon. I'm going to be talking about HIV treatment outcomes among adolescents and children in Kenya. How'd you do this?
Yes.
I can't get it to go down. How do I do? In Kenya, most HIV-infected children start ART in the adolescence period, and over time, these children mature and become more independent. In our countries, I think we are going to be seeing transition become important, or maturation of the vertically infected children who form the majority of children starting ART. Our HIV treatment programs have been in existence for almost 10 years now, and I think we think that transition into adolescence and young adulthood is going to increasingly become important to us. However, we have a proportion of children who are starting ART when they are already in adolescence, both early and late adolescence, but there is limited data that exists to tell us how they react to ART, how their outcomes are gonna be coming out as they continue to go on ART. The AIDS Relief Program was a care and treatment program in 10 countries, resource-limited countries, funded by PEPFAR. It started in 2004 and ended in 2012 when all the programs were transitioned into country-based programs. In Kenya, we had 29 faith-based facilities across the country. The program transitioned in 2012, December. By then, we had put over 72,000 patients on ART, of which today I'll be talking about children and adolescents aged between 5 and 19 years, about 5,500 of them. Tomorrow and on Thursday, you'll be hearing more about this cohort. The adults will be presented tomorrow, and we have continuous quality of care on Thursday in a poster session. Our objectives was to describe attrition rates in children initiating ART at different time points, from adolescence through from pre-adolescence through late adolescence, and also to find out if there's actually a tipping point where we actually start to see children, after we have followed them up for several years, whether there are some children who are having poor outcomes. This was a retrospective analysis of data collected, routinely collected data from the 29 hospitals, mission hospitals, for children who are starting ART between the ages of 5 and 19 years. We defined the age of ART start. We divided them into 3 groups, what we called pre-adolescents, people who started ART when they were 5 to 9 years, early adolescents, when they started ART between 10 and 13 years, and late adolescents who started ART between 14 and 19 years. We defined attrition as having been known to have died or they were lost to follow-up. Our loss to follow-up followed a specific standard procedure. People who were not seen more than 90 days after they were given the last appointment, or if attempts to trace them, after several attempts to trace them, they were untraceable. We did time to event analysis and derived our rates from Kaplan-Meier survival probabilities. I must say that we excluded transfers out because we weren't too sure whether they reached wherever they went, and we had no longer had that data. So we excluded them from the analysis. Our transfers are documented transfers. If there is a self-transfer or undocumented transfers, these were often termed as lost to follow-up, especially if they were not traced. In terms of baseline characteristics, we analyzed 5,450 children and adolescents. Overall, about a quarter of them went or attended an urban clinic. 54% of them were females, and only 2% were pregnant. All the pregnant females were in the late adolescent stage, mostly between 17, 18, and 19 years. The majority of our study population, almost 50%, were in the pre-adolescent stage, and the other 2/4 were in the early and late adolescent stage. And as you can see, in the late adolescents, that's where we had almost 2/3 were females. In our time to event analysis, as you can see in that slide, the majority of those who got lost to follow-up, according to our definition, were in the late adolescent period when they started ART. The other two groups have virtually no difference. When we look at mortality, we also see that the patients who are starting ART when they are already in adolescence period, they tended to suffer more mortality, but the difference is not as disparate as in the lost to follow-up. But as you know, in our resource-limited settings, where we can't always trace and find out the status of each patient who has stopped coming to the clinic, we can't quite tease out who has been lost to follow-up. Among those who have been lost to follow-up, who we can't quite confirm deaths. So we decided to put the two together and call it attrition or lost to program. And again, we derived our rates from the Kaplan-Meier survival probabilities. This is just confirming the last two slides that the late adolescents, the people who started ART at late adolescence, they, at 12 months, after 12 months on ART, they were showing very high rates of attrition compared to the other two groups. And as we continued to follow them up while on ART, you can see that these high rates remained high, and the difference between this group and the other two children groups continued to increase. At this point, I would just like to point out we tried to do a more refined analysis, and we separated the groups by 1 year age group, 1 year age group of ART start. When you look at the children, the pre-adolescents, they are virtually all the same. That's one thing. The second thing is that even after 12 months on ART, they still showed low attrition rates. These attrition rates did not increase much after even 5 years of follow-up. If I add the early adolescence, you will see that in the first 4 years of follow-up, they are virtually indistinguishable. But there's a group that parts company with the children and the early adolescents, that is the people who started at 12 and 13 years, such that by the time they were 18 and 17, while on ART, they started to show some increase in attrition, as can be seen on that slide. If I add the 14-year-olds, people who are 14 when they were starting ART, you will see they started at 12 months, they were virtually at the same place with the others. And you can see that by the time we had followed them up for 60 months, they are clearly a separate group from the other two age groups. When I add the 15 and 16-year-olds, again, they are a bit disparate. And now the tipping point, it's at 18 years and 17 years. They start at 12 months of ART. After 12 months of ART, they are very showing high attrition rates. And this is climbing much more rapidly than all the other groups. But it seems to level off after when they become like 21, 22 years of age. And then the strange one is the 19-year-olds. It is possible that a 19-year-old is already stabilized in terms of life skill sets because they start almost looking like teens. And we have data on youth, and it is clear that the 20 to 24-year-olds have less attrition rates than these teens, the late adolescents. In conclusion, initiating ERT at pre or early adolescence appears to protect our children against loss to program when they are on ART. However, transition into early and late adolescence among the teens may be associated with increased attrition. Starting treatment during late adolescence is associated with poorer outcomes, both for loss to follow-up and mortality. And our recommendations is to try and sort of analyze the data a little bit more to develop a better understanding of the needs of adolescents as they transition through life while on ART. Strategies to support pediatric HIV services need to take into account the impact of age at ART initiation, as well as transition into late adolescence while on ART. I'd like to acknowledge the staff and patients of our 29 sites, the organizations that were represented by in the AIDS Relief Consortium, my co-authors, and the funders, HRSA and CDC. Thank you.
Thank you very much for your presentation. Congratulations for the exceptionally good low attrition rate in the younger group. Annette.
Hi, Annette Sohn, Tradesha, Thailand. I have two questions. One, for the late adolescent group, were you able to separate those who were perinatally infected versus those who were behaviorally infected?
No.
Okay, so they were combined into one group?
Yes,
Okay.
I'm not too sure we can pick that one up out of our data.
Thanks. The second question, sorry, Carlo, is I was a little confused about how you managed the transfers. Can you explain again in terms of accounting for transfer in your program outcome?
Transfer out.
Transfer out, yes.
Okay, I'll have my colleague, who is just seated behind you, answer that.
So the transfer out is a process that has a standard operating procedure. So essentially, the patient has to be proactively transferred out. Otherwise, they are considered a loss to follow up. So they do get a letter. They do, it's a procedure. So somebody who is not there cannot be considered a transfer out. So they'd be falling under loss to follow up.
Next question.
Herb Harwell from Hong Kong. I was also curious about Annette's question, but perhaps another way to look at that is if you have baseline CD4 data, because your attrition in older patients could be because of more advanced disease rather than some psychosocial events that are occurring during adolescence. So if you had baseline CD4 data, that would be helpful, or perhaps WHO stage.
Yes, we have done this analysis and we continue to do the analysis. CD4 and WHO stage at univariate analysis are predictors of loss to follow-up or loss to program or attrition. But when you put other factors into the model, they are no longer independent predictors. But we are continuing to analyze the data.
Thank you very much for the presentation. I'm Wetundebele from Zimbabwe. I have two questions for you. In terms of your adolescents, I would like to know what their entry points were into the system. Were these adolescents that were actually diagnosed as already sick? Because I think we've had studies that show that over 90% of them were entering service as a result of an illness, and therefore that affects your loss to follow up as well as the higher mortality. But the second question, I also would want to know whether you were at a combined clinic or you were at a specialized adolescent clinic, as again there is evidence that shows that you can have better retention if you have a specialized clinic for them. Thank you.
Yeah, to answer your first question, in terms of the clinical criteria, the late adolescents don't seem to have worse progression. They are not more progressed than the earlier or the children, okay, in terms of WHO stage or CD4. And probably that's why the analysis doesn't show independent association between CD4 and WHO stage. To answer your second question, it's only now that a lot of the clinics have specialized, let's say, teen clinics. And even that, most of our sites are rural. They are mission hospitals, hard to reach areas. It is unlikely in the time period of the study that we could have had some specialized clinics for the teens.
Thank you. Please, quick question and quick answer, so we complete all the three. The next one.
Shannon Shea from Baylor, Tanzania, and I had the same question as Annette about the perinatally infected versus the behaviorally. It is suggestive in your data that at least a portion of your late adolescents would be the behaviorally infected, yes, because initially you're going along at 50% male to female ratio, 50% male to female ratio, and then it shoots up to 67% in your late adolescence. So I'm assuming, putting that together with the information that has been presented at others' presentations during the conference, it looks like the girls who are being infected in that age group are probably contributing to that.
Thank you.
Next one.
Hello, thank you, Lusenganga Dinstilieba from Uganda. So did you look at these late adolescents in terms of their out of school or in school? Could the late adolescents that were moving out of the programs actually have been going to colleges or universities in Kenya?
Interesting question. I think we'll have to look at that as we continue to look at and get a better understanding as to what are the correlates of this high attrition among the late adolescents. But so far, we haven't looked at it.
Last question.
Noreen Hone from REPC as well as Riyadh ISA. I guess part of my question has been asked, really to say, what were some of the influencing factors alongside the developmental stages of these children? Did we look at non-biological issues such as social, emotional, and gender issues?
Again, this is routinely collected data, just clinic data. We don't have all this. I think this is a good starting point to generate some operational research, to go and interview, talk to adolescents attending ART clinics. Yeah.
Okay, thank you very much.